Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Hello, everybody, and welcome. Today, I'm here with the wonderful Robyn Walsh, and I have to read all of your bio, I think. And I know sometimes when you're doing bios in an interview, it's like, oh, here's the boring part. But you guys have to listen to Robyn's bio because she has so many amazing experiences, credentials, articles, everything under her belt that I think people really need to recognize and be aware of all that you've done for the field. So Robyn Walsh, it's wonderful to have you. And I'm so excited also to I have a bunch of good questions for you, and I'm really excited to have this interview with you. Robyn is a speech-language pathologist and certified orofacial myologist, and she has over 3 decades of experience in the state of New Jersey, and we all get to hear your fun accent. Now, we have a lot of East Coast listeners, so it's not going to be fun for them, but it really is for me. My husband's from New York. His accent's pretty much gone, but yours is awesome. I can't wait to get you talking. Robyn is employed full-time by the Ridgefield Board of Education and also runs a private practice in Ridgefield, New Jersey. So working both in schools and private practice. She's a lecturer and author for Talk Tools and has been elected New Jersey Kids Top Doctors years 2012, 13, 14, 18, and 2023. Robyn received both her undergraduate and graduate degrees from Montclair State University, where she was later invited to be an adjunct and clinical supervisor. She also taught classes at Bergen Community College and Brescia University and was a former clinical site coordinator for Seton Hall University. We're going to talk a little bit about that too, because I know you're teaching courses in myofunctional therapy as part of speech pathology graduate program, which is wonderful to hear. Robyn is also the board chair of the Oral Motor Institute. We're going to talk about the OMI because it's important for us all to know about that institute. She is the proud recipient of 4 ASHA ACE Awards for continuing education and the Ridgefield Woman of the Year in 2019 in business. Robyn is currently pursuing a certification in vocology at Lamar University. If you didn't have enough, now you get the vocology, which is wonderful. So I want to talk a little bit about what you specialize in also, which is part of your bio, and then we'll get into our conversation. But Robyn specializes in oral placement, feeding, and orofacial myofunctional disorders across the lifespan. She is Beckman trained and prompt trained, and we're going to go over what those are too for listeners who don't know what Beckman and prompt are. Her private practice focuses on OPT, which is oral placement therapy, oral motor, orofacial myofunctional therapy, muscle and motor-based speech sound disorders. She conducts evaluations and Talk Tools program plans for children across the tri-state area and even for those who travel to her. Robyn also is known for her work with pre- and post-operative frenectomy patients as she prepares patients of all ages with neuromuscular reeducation and therapy plans. And she has a variety of publications and lectures. I don't know how you find time to do all of this, Robyn. Maybe you don't even know either.
No, I'm listening to this and getting tired.
You know what? It's so awesome sometimes to listen to your own bio, right? Because you sometimes have to stop and think like, whoa, look where I am and what I've done. And I'm going to talk about your publications and lectures because to step beyond doing the therapy, working with the patients, but then to also teach and also write articles, which you do so much of, is such an important aspect to bringing the field forward and progressing. And it's so important and valued. So Robyn, you are a subject matter expert. Your publications include MyoSolutions, Systematic Intervention for Lingual Elevation, Art Talk, Handy Handouts. These are all the things Robyn's published. OPT-S Kit. You also co-authored Sensory Sticks, A Sensory Motor Approach to Feeding, Functional Assessment and Remediation of Tethered Oral Tissues, and Oral Placement Therapy Goals for Speech Clarity. You also developed the OPTS tool in addition to sensational bubbles, which is fun. She also has written multiple articles for Talk Tool's website, the ASHA Leader, and written multiple articles also for Advanced Magazine for speech pathologists. You have published 5 consecutive years at the annual convention for ASHA, the American Speech Language Hearing Association. And recently, Robyn has also published in the Clinical Pediatrics Journal of Oral Rehabilitation and the International Journal of Orofacial Myology and Myofunctional Therapy. You also lecture for professional enhancement courses, part of Talk Tools. There's always amazing lectures by Robyn through Talk Tools. So I urge everybody, go to the Talk Tools website, and there's tons of wonderful webinars on Talk Tools site. And you teach oral placement therapy, TOTS for tethered oral tissues, tongue thrust, and oral myology classes that are also ones where you can receive continuing education as a speech pathologist through ASHA. And different apraxia networks you've spoken at American Laser Study Club. You were the keynote speaker at the 2024 𝐃𝐈𝐒𝐂𝐋𝐀 convention. There's even more, but I'm going to stop there because you also have a bunch of volunteer work that you do. And I just praise you, bow down to you for all you've done. I am always seeing new courses by Robyn on Talk Tools in different avenues and new articles written by you. And if somebody writes an article, maybe putting down tongue ties, saying it's a fad, saying it's not real or something negative like that, that is putting our field backwards, Robyn is one of the first to step up and write a rebuttal article and to really advocate for all of our patients and for what we do as professionals in the field. So thank you, Robyn.
Thank you. Thank you for having me.
Oh, I'm so excited to speak with you and just talk about how did you get started as a speech pathologist and then to have a specialty in oral placement, oral motor, oral myofunctional disorders. Can you tell us about that and how that came about?
Sure. It happened really early. I was lucky enough that my aunt, Janine McGovern, 𝐃𝐈𝐒𝐂𝐋𝐀𝐈𝐌𝐄𝐑, is a speech language pathologist. And I actually went into graduate school as a dance major. And I wasn't really loving it because the type of dancing that I was very interested in was like tap and jazz and, you know, all that fun stuff. I had auditioned to be a rockette. I was really into like that musical theater. And when I went to school, it was all of this contemporary dance, and it was really grueling, and I was getting sick a lot. It was before I knew that I had lupus, and it was probably like the start of it, being away living in a dorm. And my aunt made me a care package of like chicken soup and things to help me with my illness. And I went to go pick it up in the speech building, and I saw her through the two-way mirror working with a baby with a diagnosis of Down syndrome. And I went the next day and changed my major. And because I had her, she would take me, like when she went to the New Jersey Speech and Hearing Association convention, she would take me along with her. And one of the first courses that really resonated with me was Sarah Rosenfeld-Johnson. And I was lucky enough to have professors like Jerry Caracola, may he rest in peace, Joseph Atanasio, that taught us about Dan Garliner and myofunctional therapy and tongue ties. And, you know, it will be very rare, but you might come across the tongue tie. So going into my career, learning from Sarah, then it just became, natural evolution that I would go to Lori Overland's class. And I started focusing all my CEs on all the great matriarchs and patriarchs of oral motor and orofacial myology, Char Boshart, Bob Mason, the Zimmermans, Roberta Pierce, Pam Marshala, Leslie Faye Davis, Susan Evans Morris, Marcia Dunn Klein. So all my CEs were focused around oral motor, feeding, oral placement therapy. So it just happened really naturally.
That's funny. It almost sounds like you're accepting the Academy Award, thanking all the people. It's funny the way you're naming them. Good memory of all those names of people.
But they deserve it, because too
Yes.
often today, a lot of things that are taught now are passed down now as new ideas. I'm like, this is not a new idea. Pam Marshalla was teaching this even before I started in the early 90s. Pam had been teaching this, back in the 80s, and it all trickles down. Pam taught Sarah taught Lori taught me, I taught Renee, or Sarah taught Renee. And, all of us that have been around this long knew the inventors. So it's, I got to see Dan Garliner in one of his last lectures, and he was, the original creator of like the first myofunctional therapy program, like Formal One.
That I know, and that's important to credit those original people, because sometimes people develop specialties and you focus on that, and then other things kind of fade, and then other people start adopting these specialty areas and don't really know or understand the root of that,
Right.
or where that came from. And people might not know who is Sarah Rosenfeld Johnson, who is Shar Boshart, who is Pam Marshalla. Can you talk a little bit about who they are?
Sure. So Pam Marshalla is like the fairy godmother of oral motor. And she actually started the Oral Motor Institute. And she has a wonderful book called The Marshalla Guide. Now, unfortunately, Pam has passed away. And before she passed away, that's how I inherited the Oral Motor Institute, because she decided that I was the best person to take over and wanted me to run with it. We had faced a lot of scrutiny from Dr. Gregory Loff and others in the early or mid around 2006, 2007. It was never this controversy to do oral motor work. The muscles of the face matter, and motor execution, motor planning matters. And Pam really broke down the steps that you take. You can't get a child to say the R sound. Why is this happening? Let's look at the structure, the motor, the muscle. And it all goes back to Van Riper, who said, use every tool possible, use tactile cues, use visual cues, use multisensory cues. And what happened is, in Pam's teachings of how to really do this, her students, like Sarah Rosenfeld Johnson, started developing tools like the horn kit and the straw kit and the bite blocks. And that's when everybody started getting really upset. Shar used to have some amazing tools as well. So when I started training, Sarah Rosenfeld Johnson was really the therapist that was talking about how underlying muscle-based skills affected speech and feeding, where Shar was really talking about the myofunctional component and the relationship between structure and function. So, and Shar, if I believe, was actually a certified orofacial myologist as well. So Shar really gave me a lot of training in the myofunctional component, where Sarah taught me a lot about the underlying oral placement skills that we need for speech, and Lori did the brucks of my feeding training.
Wow. And all those components go together so beautifully, that
Yes.
oral motor, sensory, structure, function, muscle based. And I remember when I was in grad school, there was that controversy too about oral exercises, and that doesn't help. And it's just ridiculous. Could you talk a little bit about that too, for people who might be confused as to maybe why there was a controversy, or how that all plays into account?
Well, what they did is they lumped in all oral motor into one basket. And, they started, Dr. Loft started this term, non-speech oral motor exercises. And Shar Boshart has a podcast like yourself, where she actually breaks it down in parts to go over that controversy if you really want to hear it from beginning to end and the rebuttal of that. But what it comes down to is that for some reason, people think that speech pathologists sit around like licking a lollipop or blowing air in the cheeks and wiggling the tongue like that with no rhyme or reason, and that we claim to say, oh, do this exercise and it'll improve speech. But those of us who do this work know that anything involving oral motor, as Lori Overland would say, is a task analysis of function and breaking down the skills. Now, in PT and OT, it's never questioned. So, for example, my friend Diana is a wonderful OT, and we shared a room together for quite some time in the school. And I looked over one day, and she had putty, and she had toothpicks, and the children were taking their fingers, and she was instructing them, this is the way you're going to do it. And I said, Diana, what are you doing over there? She goes, you know what I'm doing? I'm working on a pincer grasp. I'm doing handwriting program. I said, I know, but I want to hear it from you. I want you to break it down for me. And she's like, what are you getting at? I said, well, in occupational therapy, it doesn't seem to be an issue breaking down whole to part. The end game is we want to write, but child doesn't have a pincer grasp. So you're doing some individualized exercises. But for some reason in my field, when we task analyze motor muscle skills, it's non-speech related and it doesn't work. And, you know, ASHA has fellows, right? And fellows have their beliefs. And there's some ASHA fellows that really think oral motor doesn't help cleft palate. Oral motor doesn't help articulation. And what's really disturbing about it is even when studies come out that show that it does help, ASHA will put a commentary in their evidence-based portal like, oh, this study isn't good because of this, and this study isn't good because of that. So because we had a few people that were really against oral motor, everything got thrown in together. So oral facial myology got thrown into that, and oral placement or phonetic placement got thrown into that. And working on strength, tone, and dissociation in patients with dysarthria got thrown in with that. And Ray Kent did a really nice job. I believe it was in 2017 or 2019. He wrote a paper regarding this controversy and how basically you can't throw the baby out with the bathwater. You know, we're not all talking about the same thing. And it always goes back to semantics. Well, what are we talking about? You know, are we putting a tool to help elevate the tongue and feel where the L sound is and then working on the L? Like, why do we need an RCT to prove that that works? It's just a tactile cue in therapy, you know? So it got really heated for a while where some of the best people in the field really shied away from selling products anymore. But it's interesting. No one has a problem with 50,000, you know, products on the market of word cards or, you know, bingo and fishing and teacher pay teacher. But someone invented a bite block and it was like, oh, this is not evidence-based and they're just, you know, out to make money with their tools. It, you know, Sarah put a lot of work into this and spent a lot of her own money because I call them like the original myo tools. They weren't supposed to go in the mouth, you know, and I still see therapists online. Well, what can I use that's cheaper? And another therapist will say, well, I use popsicles. Those are not safe to go in someone's mouth. So, you know, I think that the invention of some of the myo and oral motor and oral placement tools made people skeptical that they're just making this stuff up, you know, to sell product. And it's actually the reverse. We made different tools because they weren't available on the market safely. We don't want bad plastics or, you know, wood that wasn't meant to go inside the mouth.
Right. Yeah, that makes perfect sense. Tools are designed by specialists for particular reasons. And obviously, it's not the tool, but but the therapist who's using that to meet a broader
Right.
goal, right? So
Right.
anybody could
Right.
mess up using a tool incorrectly or using certain skills without linking it to the underlying goal or the overarching
Right.
goal.
Right.
And, even speech pathologists can mess that up and do random exercises without linking
Right.
it. And in
There's
fact, I remember, yeah, I
there's
remember
still
when I got
board
started.
games. There's board games on the
Yeah.
market. Go around the board and make raspberries or do this. And that's not really goal-based. But
No.
what's interesting in being in the vocology program, there are exercises that they use working on respiration, phonation, making sure the jaw's in the right position, doing semi-occluded vocal tract exercises to make the vocal folds oscillate more rapidly and in an efficient way. And guess what? They look just like our oral motor exercises that we use for speech. They're using straws. They're using different labial postures and tongue trills like we would do in myofunctional therapy. And
Yeah.
no one is, having a temper tantrum that it's not evidence-based.
Right. That's just, yeah, I can see how that can be frustrating. I
Yeah.
remember when I first did my internship in the schools before graduating from my graduate program. And I think I could see how that therapist was not linking these like exercises, quote unquote, to what the overarching goal was. So I think anybody could mess that up if you're not a good, skilled therapist working to achieve a goal. So everybody would sit in like a circle in a group of kids at the table and do like hot dogs or tongue tacos. And then they might do like blowing raspberries and do a few things. And then they'd all break off and work on their certain articulation sounds, but it wasn't linked. It wasn't
Yeah.
individually linked. And I feel like
Why
that's
is that happening?
what'd
And
you
why
say?
is that happening? Because the
Yeah.
graduate schools, even though orofacial myofunctional disorders are part of the ASHA standards for accreditation for a college or university to be accredited by ASHA, they barely touch upon it and then will tell the students it's not evidence-based. So why are they not executing? It's not their fault. They're not learning it the proper
Exactly.
way.
Yeah, and I think the patient, the client needs to be linked and they need to understand if they're old enough to understand perhaps what this exercise or movement is doing. And I think this is what differentiates a skilled trained therapist as well is in any of the work we're doing, it's not exercises that are the goal, right? We're not throwing random exercises like let's do 10 of these, 1 minute of that, 100 reps of that, but it has to be linked to the patient's disorder, their weaknesses, and step by step how we're getting to that overall goal.
Right.
So I get frustrated. I get emails. You probably get the same thing where it's like, give me your 5 best exercises. I don't respond to those. Yeah, it's like, listen, patient, what's going on? We have to, really do a thorough evaluation and then work with the patient to know how we're getting to the goal. And part of our speech pathology program was like really strict task analysis where you have your goal and you have to break it down into every little constituent, every component, how you're going to achieve that. And so I can see how perhaps that oral motor controversy can come about if therapists might be using certain exercise or techniques without the true purpose. But can you explain what is oral motor therapy? What is oral placement therapy?
Okay, so at the Oral Motor Institute, we have this really nice infographic, and I think I've shared it with you, right? So the umbrella is oral motor, right? The muscles, the neurological system, the structure of our oral facial complex. Okay, nice term coined by Christy Gatto. And there's a lot of different diagnoses that fall under oral motor. So if oral motor is affected, you might have an oral facial malfunctional disorder. You might have hypotonia, hypertonia. You may have difficulties with oral placements. There may be dysarthria. There may be apraxia. There may be structural problems like ankyloglossia, right? So oral motor is really related to feeding and swallowing, like what muscles and what nerves are fired in order to complete the 4 stages of a swallow. The preparatory stage, bringing the food into the mouth, chewing it, then transitioning it to go to the pharyngeal port, and then the pharyngeal part of the swallow and the esophageal part of the swallow. Oral motor is going to help with the oral prep and transit phases. So we look at how is the child chewing, what are the cheeks doing, do they have enough jaw strength, is their lip closure, are they breaking down the food, are they collecting a bolus, are they able to transfer it across the midline? There's a lot of norms there. So someone like Nina Johansson or Melanie Poddick or Lori Overland that are teaching pediatric feeding courses are, zeroing in on not only the muscle, but the neurological as well as the sensory system and how they're all connected and how that affects food choices and the handling of food and drink and even saliva. Where oral placement is a modern extension, and I did this poster at ASHA, it's a modern extension of Van Riper's phonetic placement approach, where we're taught in school, this is how you make the L sound. The tongue tip has to go up, and it's a continuant, and it's voiced, et cetera, et cetera. And we're taught in school what the placements are, but what happens when you do traditional articulation therapy and they can't do the placements? That's where Sarah Rosenfeld Johnson came in, and her and Diane Barr wrote a paper on this in the Communications Quarterly, that not every patient, student, or client can respond to look at me and say what I say, or watch my mouth and do what I do. And that's what happened to me when I started in the public school. I thought I was well equipped. Well, I'm just going to tell them, put your tongue up to the spot and bite your teeth together and hiss like a snake. And all of these kids had open bites. They were sucking their thumb. They were chewing their fingernails. They couldn't breathe through their nose. They had a tongue tie, all these OMD symptoms. And no, that traditional model wasn't going to work. So oral placement is a technique where you're working on the tactile cues to facilitate the placement and cue fade them once they get the skill. And it also considers all the subsystems of speech like respiration, phonation, jaw stability, jaw grading, all the movements of the tongue, protrusion, retraction, lateralization, elevation, back lingual palatal suctioning, or back tongue elevation. It considers co-articulation and the dissociation of all of those movements. So it involves muscle, but it also involves motor.
Okay,
so they're definitely, they're interrelated, but they're different. We're not really using oral motor for speech sound production. We're really using oral placement techniques. And I even teach that when I teach my myofunctional coursework. It's, looking at the underlying cause and making proper referrals to make sure that's taken care of, like being able to breathe through the nose and making sure the tongue's not restricted. But when it comes down to the therapy, making a taco tongue isn't going to help someone's speech. You have to specifically narrow in on, well, what is it that you want the articulators to do? If a child has a tented upper lip and can't get lip closure, you have to deal with the underlying physiological cause, and then you can work on oral placement skills to get those lips together.
Mm-hmm. So we have like feeding therapy, we have oral motor therapy, which is not for speech sounds, but for the feeding, the swallowing, the movement component.
Right.
And then oral placement would be specifically for speech sounds, but those tactile cues and coordinating breathing, respiration, movements, tongue-jaw dissociation, all that. And then how would orofacial myofunctional therapy defined in relation to those?
So it really overlaps, Nicole. So I created the 4 myo domains, and certainly what's in the domains isn't my invention, but the unique way I approach them, right? So the first one is absolutely your favorite because it's airway, all right? And it's the most important because from a physiological level, and I have to give kudos to Caitlin Shrum from Southern Speech and Myo, because she's an OMI board member, and she just sent me a brilliant infographic that is showing that airway is the foundation, right? You have to be able to breathe to live. And that includes your sleep, your oral resting posture, because that's all related to the airway, right? And then the second level is feeding and swallowing, because you also can't live without nutrition, right? So if you have an OMD, if you have a structural component that's affecting your function, okay, physiological component, there can be manifestations in feeding and swallowing. And that can range from a tongue thrust to having proper or not having proper nutrition. And then the third domain is structure. How do maladaptive functional compensations impact your structure? Or how does structural anomalies affect your function? So a tongue tie may cause a lisp, but poor oral resting posture may cause a malocclusion. So it's that interaction. And then the fourth myo domain is speech and how it affects not only articulation, but we're starting to see research like I was involved with the Breathe Institute. How does it affect voice? How does it affect resonance? And many clinicians, though not documented yet in external research, see a link between orofacial myofunctional disorders and fluency disorders. So when we talk about orofacial myofunctional disorders, I think what gets very confusing is it's always looked at as a therapy modality. And in reality, what we are looking at is a disorder that's treated by multiple modalities across the lifespan. Because as speech pathologists, we can be experts in OMDs, but we're not the person taking the adenoids out. We're not the person doing the frenectomy. We're not the person doing the head and neck alignment that's going to help with the TMJ. That's going to be a PT. Oh, I can be an expert in orofacial myology and not know anything about breastfeeding. I do because I have training in breastfeeding, but I might not know about that. And I need the IBCLC to mitigate preventing orofacial myofunctional disorders by helping both mom and baby at the breast. So if we look at this as a disorder, all these different modalities, Nicole, actually come into play. Kids with OMDs benefit from a pediatric feeding specialist, a pediatric swallowing specialist, because they're not even the same thing, right? Feeding is the act of placing the food in the mouth and helping with utensils and developing the oral motor pre-feeding skills, where pharyngeal and esophageal swallowing, that is a dysphagia specialist on a whole nother level, right? That's a totally different type of training. And then we have speech pathologists like those of us at Talk Tools that are experts in articulation and oral placement therapy, where let's say a dental hygienist that is trained in orofacial myology is not going to be able to do that component, just like I can't do wound care because ASHA and my license doesn't say I can. So orofacial myofunctional disorders is just that. It's a diagnosis. And orofacial myofunctional therapy is just one modality that can help these patients.
And that's important to understand and differentiate. We all have different skills and different training, and it's important to know our limits. For example, I don't work with infants, and I don't work on feeding skill. I'm not a feeding therapist. And I know I could do it if I sought the training and all the work to learn to do that. I feel like I'm capable, but I don't do that. That's not my specialty. So when we get referrals for the little ones, a 1-year-old feeding case, like I refer those out to the feeding specialist, right? And I would love to really get that training because I know that early intervention component is so important, but I don't have the skills to take a case like that. Whereas
Right.
I might work with a 1-year-old who might have delayed language development on the floor doing play-based therapy for babbling and speech and that component, but not the oral motor, oral sensory feeding aspect. So it's really interesting when we know our limits and know the details and what's entailed in treating cases at different ages to
Yes.
reach to our colleagues, right?
Yes. And what's happening is that professionals are going for orofacial therapy training, and then they're trying to make that work for special needs kids or toddlers. And they're coming up with trendy names, like mini Mayo. And it really, if you do birth trainings, it's not the same, because in 0 to 4, we're more superimposing, like we're creating sensory motor mapping skills. Like, I might take a Sensi tool and add vibration to the side of the tongue, and I'm going to trigger a neurological reflex for that tongue to gravitate toward the molar. Where in a 10-year-old, I'm just going to say, I'm going to put, a Cheerio on your molar, and I want you to take it and move it to the other molar. And, I am a strong believer, like even for yourself, you might not ever want to treat, it's hard to treat babies and toddlers. I do a lot of that here. And trust me, it's my 12-year-old neurotypical OMD patient that's going through an expander and had a release or is going to have a release is a lot easier than trying to navigate getting a 2-year-old to accept therapy tools inside of the mouth,
Yes.
if they have a diagnosis of autism or Down syndrome or CP, it's a whole different skill set. But knowing about normal 0 to 3 mouth development and what happens in 0 to 3 is critical, even if you only want to work with 4 and up and do classic orofacial myofunctional therapy. Because what I find with a lot of my patients is I'll have an 8-year-old, a 12-year-old, an adult that has unresolved infantile reflexes that never developed the ability to cross a bolus across the midline. This goes back to oral dysphagia training, and it goes beyond the scope of orofacial myology because, with swallowing, you may have aspiration, penetration, choking, vomiting. You have to be really careful, and you have to know those signs. Like I have a 4-year-old I'm evaluating that it's very rare, but he still has laryngomalacia. If you're only trained in orofacial myofunctional therapy, you're not going to pick up on that sound, or I have patients that come in and their speech pathologist told them that they have apraxia, but they're tongue-tied. But in reverse, I'm getting patients that come in, I think my child's tongue-tied. Your child's tongue-tied, but they also have motor praxis issues. So we have to really think about timing of release, working with the release provider, because they're going to have probably even more problems after the release because they're already not controlling their tongue in a normal manner. So the release isn't going to be the end all be all or even the myofunctional therapy, because we're going to need to add in those evidence-based approaches for apraxia, childhood apraxia of speech.
Yes, picking up on those subtle differences because you have the training in diagnosing apraxia or knowing how to rehabilitate such issues with motor planning or dysarthria issues with dysarthria when combined with other OMD characteristics. So that's a
Yes.
really important skill. And yeah, it's interesting. One of my colleagues at the office she started treating the young children and took some courses, and she's like, you know what? It's not for me. Like those ones under the age of 4. She is amazing. I mean, the kids love her. The little ones love her. So she does great with the language delayed children and play-based therapy, children with autism, spectrum disorder. But when it comes to that specific oral motor, the child with what you would picture as like an OMD in that young age, open mouth, drooling, where you need those specific oral sensory motor techniques, feeding techniques, working on the half straw, chewing, all these things. You're applying specific skills to target the reflexes and getting into the mouth of those little ones where they can, working up to allow them to accept that. She's like, that's not for me. She's like, I just don't want to, I can't do that, but she can treat in other ways. So kind of my point being, with each age and population, there's certain things we might be able to do and feel confident and comfortable doing. And there might be certain aspects of their care that we need to refer to other people. Even though we might be working with the same age child, we might need to refer to someone else who has specific skills in that domain. So that kind of helps explain, like, if you could summarize, like, why oral facial myofunctional therapy is not appropriate for children under the age of 4. You have a really good paper on that in children with special needs. Can you kind of summarize that so people might understand?
Classic myofunctional therapy was developed between dentists and speech pathologists in the avoidance of orthodontic relapse. And when I started in the field, it really wasn't being started with children until 8 and up, right? Because braces were going on in middle school and high school. So orthodontics has evolved. And I think what's happened is, because orthodontics has evolved and we know myofunctional therapy is a very important component, the age has now, gone down to 4, because a 4-year-old can sit in a chair and respond to, imitating different exercises and engaging. But classic myofunctional therapy relies on volitional control. And there's always going to be, for an OMD patient, there's going to be the nexus of structure and function. If there's no structural component, there's no OMD. That's going to be a dysarthria or a low tone. You really have to have both components there. And the problem is, because the training for working on pre-feeding oral motor skills is not really touched upon in oral facial myofunctional training, trying to take those principles and, get a 2-year-old to do them. A 2-year-old doesn't have the cognitive ability or the self-monitoring to monitor their resting posture or think about tongue to spot, or they don't have the motor muscle, neurological, physiological skills to even be expected to do those oral facial myofunctional exercises. What's taught in a classic like OMT intro course, like whether it's Christy Gatto or Mary Billings, or a lot of other great instructors, they're not spending a heck of a lot of time going through the 0 to 3 development, asking a 2-year-old to do lingual palatal suctioning or to self-monitor the swallow. The adult swallow is developed by 24 to 36 months, and we have to look at neuroplasticity. We have to look at age-appropriate norms. And we don't ignore the disorder, but we use the evidence-based approach. So what are we looking at 0 to 3, and then that transition year from 3 to 4? We're looking at a checklist, and Lori Overland and Sarah Rosenfeld Johnson have done these norms. Morris and Klein have done these norms. Diane Barr has done these norms, where we're looking for certain things to occur. What happens during teething? When is the tongue going to start to retract? A perfect example of this, Nicole, is this trend to have parents waking their babies up in the middle of the night to check for lingual palatal suctioning. A newborn shouldn't have suctioning. What they should have is light contact of the tongue blade against the palate. And their motor skills at that age are protrusion, retraction with tongue cupping to the bottle, teat, or the breast nipple for effective suck, swallow, breathe. So to expect a baby to do, no, if their tongue is up there and they're laying down due to gravity, you pull their tongue, their jaw open. Yeah, you're going to see and hope to see that the tongue is elevated. But how are you treating that at that age? You have to treat it through pre-feeding, Beckman oral motor, feeding therapy, working with the IBCLC in developing the muscles. The cheeks are involved, the top and bottom lift are involved, the appropriate tongue cupping. But you can't take a principle like round the clock oral resting posture. Newborn babies are floppy.
Yeah.
They're brand new. They're not walking. They're not sitting up on their own. Their tone is nothing like a 4-year-old child or an 8-year-old child or an adult. And it's that level of understanding that you're going to receive as a speech pathologist, as an occupational therapist, and sometimes even physical therapists who take a specialized interest in feeding and pediatric feeding and swallowing. That's where we learn the appropriate modalities to treat them. And, not until social media really did this concept. It's like, well, babies have muscles, so we'll just, say it's myo for babies or baby myo. But it really isn't. It's muscles, but it's a much different training and learning, about the cranial nerves, about infantile reflexes, and about this rapidly developing oral motor system and how we can be preventative and mitigate issues, and how we can be, as Lori always says, one step ahead. If a baby has, let's say, Down syndrome, or they've had a tongue tie released and they're approaching solid feeding, we need that PT or OT to look at posture and alignment. Can they hold their head up correctly? We need the feeding expert, the OT or the SLP, to rule out any signs of aspiration, penetration. Have they developed the necessary oral motor skills before we start feeding?
Yeah. So
before we start solids, I have a discussion just this week. Why isn't Robyn, why aren't you starting the solids? I don't know, because he has no tongue retraction and he can't sit up in the high chair and doesn't have any head and neck support. I referred him to PT. He's not ready. I'm not going to tweak him. That's not something that's going to be taught in a classic myofunctional therapy course.
There's so many details to that young population. I mean, it's a little overwhelming to know what you have to know exactly what you're saying. What is normal? Knowing what is normal. And a lot of the work is cranial nerves, reflexes, and we can't apply some overarching program of exercises or overarching goal, lip closure, tongue sucked up, to these babies under the age of 4, because that's not what it is. That's sort of like a superficial treatment, right?
And wound care, stretching, and active wound management also is not orofacial myofunctional therapy. So this is what's also confused both physicians, dentists, and therapists, in that they're going to these interprofessional conferences and they're learning about pre and post-op, but they're not differentiating pre-feeding oral motor, because I look at those as synonymous, okay? Pre-feeding oral motor, orofacial myofunctional therapy, and active wound management. And this was the paper Lori and I just published in the IJOM, in saying, when you're working with complex populations, you're working with babies, infants, and toddlers, and you're going in there and, you're listening to the surgeon, like, I want the tongue lifted up. That's not myofunctional therapy. That's a goal that the surgeon has created in terms of wound healing.
Yeah.
And we have to be really careful. Right. Wound management, wound healing, active wound management, stretching. It's got a lot of different terms, but you know, I encourage therapists all the time, look at your license. Do you see anything in there about oral wound care? I'd be really careful in telling a parent, well, I'll help you with the stretches. No, you're helping with the neuromuscular re-education. And a lot of it looks the same, so that whole concept of the 0 to 4, the special needs, semantics are really, really important, so I'm not saying at all that we ignore it. I'm just saying that we have to assign the right professionals with the right modalities within their scope of practice to perform those modalities.
Right. And that makes sense. And even with special needs populations, so we get a good bulk of referrals who are children or even adults with cerebral palsy. And to me, that feels like a really good example because sometimes they're looking for myofunctional therapy. And you get that, you're like, that's not an oral facial myofunctional therapy program. That's not like your 8 to 10 sessions where, that is similar to that oral sensory motor therapy,
Yes.
working on reflexes, right? Working,
Yes.
using different talk tools, right? And different stimulations, vibrations, different things like that to trigger different reflexes and movements. And that gets confusing if somebody only understands oral myofunctional therapy or if the patient is being referred for that and explaining to the parent or the caregiver how we're going to try to get lip seal and work on the drooling, but it's not oral facial myofunctional.
Right. It's a modality. And every day unpopular opinion, but I hate the term myofunctional therapist for that reason. Because every day I get emails and calls. I need a myofunctional therapist. My child has Down syndrome. I need a myofunctional therapist. My baby's getting a tongue tie release. I need a myofunctional therapist because, my father just got diagnosed with Parkinson's. And then when I tell them that's not what they need, but I can treat it with X modalities, sometimes they won't come because the internet has told them what they need. And, I'm a licensed speech pathologist and I specialize in oral facial myofunctional disorders. And I know how to do oral facial myofunctional therapy, but it's one tool in my toolbox. I can also do prompt therapy for motor speech, and I can do Beckman oral motor for things like Down syndrome, CP, Bell's palsy. And when you lump everybody into one term, that's not a licensed profession. There's no license for a myofunctional therapist. It's always been, since I've been in practice until the last couple years, looked at as a modality that's under different professional scope of practice. So it's really important that I can only speak for my own field as speech language pathologists. We use the terminology for which we matriculated and what your licensure is in. I also don't call myself a feeding therapist. I'm not a feeding therapist. I'm a speech language pathologist, and feeding is a feeding disorder or a pediatric feeding disorder is another diagnosis that falls within my scope of practice for which I've had extensive training in.
So you would say you're a speech language pathologist with training or with expertise in or facial myofunctional disorders.
Right.
Therapy,
it's like the same thing. I'm a board certified oral facial myologist. I sign that under my title as a speech pathologist with my licensure numbers. And hopefully by January 1st, I'm also going to be a certified vocalogist. But again, that's going to be something that goes underneath the speech language pathology title.
Yeah.
How did I get that certification? Because I'm a speech therapist.
Yes. And if it all went after your name, you'd have the longest name that exists on the planet too. So with all your areas of expertise.
Right. Right. So
vocology. Yeah.
It's just too much, it's just too much. And if we lean into that notion that oral facial myofunctional therapy is for anyone and can be done by anyone, We just made a reel through the Oromotor Institute, and it's like a little bit of mockery at this concept. Like Caitlin says, I just got my hair done. She had a license to do it. I said, I just got a manicure. They needed a license to do it. Casey's in the bathroom. Hi, I need a licensed plumber. My kids are flushing stuff down the toilet again. And then I talk about, like, to think that you don't need a license to work on someone that's going to be swallowing food and liquid, that's just absurd to me.
Yeah.
You know,
And our license is governed by our state, and we have regulations within our state that is defined in our license. So,
yes.
you know, part of that, and it protects the patient and also protects us as a practitioner.
Yes. Things can happen.
I don't know if you get this a lot, maybe in your area, I don't know, but I do get like subpoenaed a lot for patients maybe suing their orthodontist or their dentist, and the attorney wants all of our records because the patient worked with us to use in a court of law against, I mean, maybe I'm in a litigious area, but this is pretty common that we'll get this, you know, they want notes, all of our notes, documentation, insurance codes, things like that. And, you know, I want to make sure I'm practicing within my license because that's there. So it's all, there's a lot of details to what we all do. And there's all different components and areas of specialty, areas of expertise, different ages, different populations, different disabilities. And it's important for us to know our limits, refer to others, because it really is a team approach with our patients, right? Not one of us can do it all. I want to talk, as we're wrapping up, a little bit about some of your favorite research. Now, I know you've done a lot of research. You talked about OMDs and voice. So if you could talk about that article, orofacial myofunctional disorders and the link with speech sound issues. And perhaps that's the domain of tongue tie or general OMDs.
Yeah.
And then the last thing is the relationship with OMDs and fluency, because I know there isn't research yet, but all the SLPs who are in this loop and get it, see that there's a really direct link between that. So maybe let's start with voice, that voice article that you wrote.
So this is what got me into going to the vocology program. My dear friend, Dr. Zarush Zaghi, he seems to find projects for me, right? So they were looking at the Breathe Institute, patients that were coming in that were professional voice users complaining of all this muscle tension, and, you know, they're being scoped. And my friends in New York, Dr. Anthony Yan and Dr. Jenny Cho, are house doctors at the Metropolitan Opera. I mean, is that not amazing, right? And have years and years of experience. And they're also seeing a connection that these patients are coming in, they don't have vocal fold pathology, but they have all this strain, the SCM muscles in the jaw, they're having TMJ, and lo and behold, they're evaluating them and they're tongue-tied, okay? So none of the traditional voice methods like the SOVT or the breathing exercises, the relaxation exercises were working. So what do you think about this, Robyn? We have these cases. Can you look at the data? And we worked together, and therapists at the Breathe Institute, both SLPs and RDHs, did preoperative myofunctional therapy because they're all adults, right? And they focused on the tongue tie component, not the voice component. And the patients were surveyed, and over 90% of the patients, so it's a case series, there were 12 patients, I believe, and, or is it 10 of 11 or 11 of 12? I got a lot of data in my head, Nicole.
Yeah, it's okay.
But over 90% of them had common themes that were improved. Like one singer was to the point where she could only sing for like 20 minutes, and then her voice was just giving out, and she was singing easily for over an hour. So we're proposing that if a singer is having this problem and voice methods aren't working, they should be sent out for a tongue tie evaluation and perhaps pursue myofunctional therapy with the release. So we want to expand on this research, certainly. And I started working with some professional voice users. And I live right across the George Washington Bridge. So a lot of Broadway performers, a lot of opera singers and actors live here on this side of the bridge or close enough that they can come to me. So this is something new I'm really branching out into, because I was only pediatrics up until 2000 during COVID. And, I started getting interested in this area. So that is really a landmark paper. And Nancy Solomon and I, Nancy, if you don't know her, is the editor-in-chief of the IJOM. And interesting, she's editing an orofacial journal, but her expertise is in voice. So her and I took this data, among other things, and correlations, and looking at the structure, just, where's the genioglossus? It's like the neck bones connected to the shoulders and all of that. These muscles between the larynx and the base of the tongue are connected.
Yeah.
So I'm sure more is going to come out on this. And then you wanted to know about TOTS and speech, or OMDs and speech.
Yeah.
Right?
And one thing is I've had a few patients, adult patients, who have had issues with vocal fatigue. And after tongue tie release, that went away. Everything felt more relaxed, less strain upon speaking. Patients clearly have reported that. So it's your research backs that up. OMDs and speech, or tongue tie and speech articulation issues.
Yes. So this is the big area where our national organization is really not accepting of this. I've tried 5 years in a row to get into ASHA with my paper or my literature review in looking at speech, sound disorders, and tongue tie. And every year there's a new paper that's showing this correlation. Like, for example, the 2020 paper that I was so lucky that Dr. Baxter asked me to be involved in looking at the improvements of multiple areas of function, but speech being one of them, right? And even having patients in that study that were low verbal and started using more words after tongue tie release. And every year they reject me. And it's always like, oh, you work for Talk Tools, you're biased, or this research was biased. And I'm putting in the papers, like by Dr. Kummer, that say, oh, no, they can just compensate. There's rarely a need to release a frenectomy, and I'm opposed to frenectomy. And ASHA tells us that we can't even say that as speech pathologists. Like, it's not up to us whether the child needs to be released or not. So there is quite a bit of research from 1959 and beyond that show correlation between tongue tie and speech sound disorders and specific sounds. So there's even been papers, like Dr. Sharon Smart is a dear friend of mine, but she was involved in a paper that had data that showed that the kids that had tongue tie, whether it was treated or not, needed more speech therapy and had motor execution issues and common sounds, but the end data in the study didn't show a correlation between tongue tie and speech. And Dr. Smart has talked to me about it and said, you know what? I don't think we had a large enough case sample. We probably need more participants, right? So research gives us baselines. Case studies are important. Case series are important. Cohort studies. And it's very disturbing that ASHA looks at these papers, and because they're not by ASHA, they like somehow don't matter. Like, they find a way, like certain TikTokers that, run the misinformation hotline, the pediatric feeding SLP. She likes to chop up the research and, basically this is garbage. But there's too many papers now that are showing this common denominator. So I think instead of, and the OMI has a petition right now that we want, and I hope all your listeners sign it. You can go to the, social media, Instagram OMI page, and it will be there. We're demanding that ASHA has an OMD area to submit to for convention, because every other area in the clinical practice portal for ASHA has fair representation. Motor speech kids, they have a committee at ASHA. Pediatric feeding disorders, they have a committee at ASHA. Fluency, they have a committee. Voice, they have a committee. OMDs, crickets. So
That's
I can't
absurd.
blame, I can't blame the people that are reviewing it, because they're not studying this. They're motor speech people, so they're probably working with apraxia, or they're craniofacial people, so they're working with cleft palate. They're not studying tongue tie and speech the way I am, right? Or the way Mary Billings is, or Linda D'Onofrio, or you, or Christy Gatto. We're the people, we're the therapists that need to be on this committee and reviewing the papers, because we'll know if the research is valid and where it's coming from. So I'm thinking that I'm writing something with Dr. Baxter right now. I'm really thinking that after I'm done with vocology, that I'm going to call on my PhD friends like Dr. Sharon Smart to look at this research with me and do a literature review and set the groundwork so that people understand this correlation. Because to me, it's basic science. If you can't move your tongue, you're not going to have proper articulation. It's silly to even negate that could be correlated.
That's why some of those things seem so ludicrous. It's like A plus B equals C. Like, how do we not see? I don't know, but it's really great what you're doing, and everybody needs to go to Oral Motor Institute to sign the petition so ASHA can recognize OMDs in that capacity. That's really important. And the last thing is that correlation between fluency disorders, so stuttering, and do you think it's OMDs in general or tongue tie? There's a correlation.
I think that airway and respiration affects fluency. I think that a tongue tie can impact fluency, because again, how is the larynx abducting and adducting? How is the vibration in the larynx, and how is that coordinating with the articulators?
Mm-hmm.
Is there an anxiety component? Probably, but this is my 30th year entering the school, and every single stutterer that I've had in my caseload has had comorbidity of either tongue tie or blocked nasal passages. They also have airway dysfunction, whether it's asthma, chronic rhinitis, tonsil and adenoidal hypertrophy. And those patients or students that overcome their stuttering, it usually happens simultaneously with release and orofacial myofunctional therapy, or adenoid and tonsil removal with retraining of nasal breathing.
Now, I wonder also if, and we couldn't differentiate this, but if there's a sleep breathing component, because we know most of our patients have sleep disordered breathing due to the structural and soft tissue. So anything you have a genetic tendency towards is going or is likely to get worse if you're not sleeping well. So those who have that genetic tendency to stuttering, disfluency, if they have an OMD, their sleep quality is impacted, there might be more likely to have problems with their speech expression. So there might be that component too. Super interesting. And one other thing my husband and I have noticed, he's a physical therapist, and he suspects there's a correlation between tongue tie and thoracic outlet syndrome, which has been seen in many of his patients. So that's another interesting potential avenue to study and research as well. But I need to respect your time because you have a whole caseload of patients the rest of the day.
Yes,
and I really
my day is just beginning, Nicole.
Oh my gosh. Thank you so much for this over an hour of all this information. People should check out your website, ask you questions if they have questions, sign that Oral Motor Institute petition. And again, thank you for all you do. You are just a blessing to the field. Thank you.
Thank you so much. As are you, Nicole. Thank you.
Thank you. Thank you so much for joining this episode of Airway Answers. I'm hoping some of your airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much and join us for the next one.